All of you. This is very heartbreaking to talk about Prachi ma'am. So just we are missing her. Maybe we'll take care our legacy forward. So basically, why the monitoring in CPB is very complex. So when we read our anesthesia book, the first line written in Kaplan is the junior anesthesia fellow is asking the senior fellow, why should I monitor the patient when the patient is on pump and the perfusionist is taking care of everything, including the pump flow, giving drugs, everything. Why should I monitor? Then the senior person is telling, when he has given the example of a MiG 17 and told that when the MiG 17 is in autopilot mode, something goes wrong. Who is taking care? The pilot, the crew members, even the persons who are boarding. That same thing is applicable when it is in the CPB machine. It's a complex interaction between the surgeon, perfusionist and the anesthetist. So if it goes in autopilot mode, everything is smooth, it is smooth, the patient will come out. If something goes wrong, like whole morning we discussed about the disasters, how to manage everything. If something goes wrong, it's a closed loop communication between all of them, that only will save the patient. So we should be very careful when the patient is on pump also. So what will be the anesthetic consideration in pump? So it will be basically in three phases: the pre-CPB phase, the CPB phase and the post-CPB phase. The pre-CPB phase is similar for all surgical patients, except that we are taking care of more sicker patients with very low ejection fraction, more sick hearts and stenotic lesions like that. So the induction should be very smooth. Many times found profound hypotension can occur during the induction phase, and sometimes the patient crashes and you have to go immediately on cardiopulmonary bypass. So in most cases we have to put some pre-induction invasive monitorings so that we can continuously monitor the pressures and as well as slowly induce the patient to avoid all those things. In most cases we need to tailor the needs of the patient. Suppose you are doing for a ASD patient, you know that the patient may not have some much hemodynamic disturbances. I can extubate the patient early, so my anesthetic management will be different. I will not be going to the details, all those things. And at the same time we should be able to identify what are the high risk patients, so that I will be very careful. And the same time the patient these are the group of patients where there will be high chance of organ dysfunction. So I should be able to identify all those patients. And for all the safety features, there should be many checklists. So the pre-CPB checklist, anesthesia machine checklist, as well as the pump checklist, all you should be thorough with. During the CPB, the main thing is a non-pulsatile flow. So the monitoring will be difficult in this phase. So at the same time, you have to maintain the depth of anesthesia. As according to the US claims, this thing around 50%, between 30 to 50% patients can have awareness during the CPB phase. So the incidence, the reported one is between 1 to 2%, but there can be 30 to 50%. Even in Indian scenario, we don't know exactly how many patients will are aware during our time. And you have to maintain the proper anticoagulation depth. So for the juniors, it is the standard is ACT should be more than 480 to go for pump, and you have to maintain the hematocrit. We maintain around 21% hematocrit and monitor all the organ perfusions properly, and that should be always the closed loop communication should be there. The post CPB phase, it is the most crucial phase, the weaning that is during the weaning up from the CPB, and you have to prepare the patient to get from the bypass. The inotrope, spacing as well as IBP, all things should be ready, and adequate hemostasis, blood and blood products, everything should be ready. So the different complex monitors what we need during CPB, as everybody discussed in the morning, the CPB can do four purposes. First is to take care of the heart, that is circulation, then the respiration, the job of the lungs, then cooling and warming of the patient, and to give the surgeon a bloodless and immobile heart. So we have to monitor all those things. I will be discussing all those things later. As well as the coagulation part also you have to monitor, because the patient can have bleeding also disastrous, even a coagulation during the CPB also disastrous. So then the different hemodynamic monitoring what I will do in CPB. The basic thing ECG, though you will have a immobile heart, if the patient starts beating during the CPB phase, the first one will be the anesthetist who will tell, sir, your heart is beating, I am getting some spikes in the ECG. Then this is the time to give one more CP. Next you can see that during coming off you will see the heart rate, rhythm, STs, and you can see for that myocardial preservation as I have described. Then you can see for the invasive blood pressure. The blood pressure what we measure during the pump is a pump pressure, that is a mean pressure. We will not get the pulsatility, so we cannot get a systolic blood pressure or diastolic blood pressure. The mean pressure or pulse pressure will be finding. So you have to maintain that one in your normal range. Whatever the patient's normal range in the pre-operative period, that only you will be maintaining. Suppose you are getting a hypertensive patient, he is used to the rightward shift, so you will be maintaining the pump pressure on the little higher side. So for that we will be doing either one of the invasive arterial cannulation, femoral artery. Most of the cases we do with femoral line, because the radial artery sometimes it will damp during the long bypass time. In many cases radial line you will prefer, like when you need for selective arterial selective perfusion of the brain or PDA ligation in those cases. In central venous pressure monitoring for your fluid status, filling status, and during weaning off it will be useful. Then other hemodynamic monitoring like pulmonary artery catheter, where you can find the mixed venous oxygen saturation will be of more value. Pulmonary vascular resistance, systemic vascular resistance, cardiac output, all you can calculate. Similarly, on the minimal invasive cardiac output monitors, they are very useful, but in the immediate post-op period they may not be useful because the trace will not be adequate, and if the patient is arrhythmia, then this minimal invasive pulse contour analysis cardiac output will not be effective. Next we have come in big way with the transesophageal echoes. This will give the real time scenario. We can assess the cardiac performance of both right ventricle, left ventricle, regional valve motion abnormality, different valve dysfunctions, MRs, ARs, everything we can identify. Any residual ventricular septal defect, intracardiac AR and thrombus, everything can be you can see. This is a case we have done yesterday only. This was a case for mitral valve repair. So if you have a T, you can exactly point out where is the lesion, and accordingly you can plan. The first is showing a severe MR. First picture is showing the severe display. First picture is showing a severe MR, and the next one is to see where exactly the lesion is. So it is this is the P2, P3 level, and we have found some caudal rupture, and we have repaired with neocordy and with the ring. So the last one is with the after the repair. So monitoring on the pump, you will be able to see the pump flow, which will be basically the revolutions per minute, and which will be tailored to the cardiac index of the patient, that is basically the body surface area, and according to the temperature. So under moderate hypothermia or normothermic condition, the required pump flow is between 2.2 to 2.8 liter per minute per meter square. Basically the purpose of the pump is to satisfy the oxygen needs for the different organs with like the systemic oxygen consumption through the adequate pump flow, that is the DO2. So the DO2 should be the pump flow rate into oxygen content, which basically depends upon the hemoglobin as well as the saturation. So ideally the adequate pump flow should be based on the body surface area, temperature as well as the DO2s. So the pump pressure is not the surrogate for the adequate perfusion. Why you want to tell that? The mean arterial pressure is cardiac output multiplied with systemic vascular resistance. So sometimes the mean arterial pressure can be high because of the increase in the systemic vascular resistance. When there is hypothermia, the SVR will be increasing and you will have a more MAP. But that doesn't mean that the cardiac output is adequate. So in those cases, you should not decrease the pump flow. Rather, you have to dilate the patient so that the cardiac output is adequate, pump perfusion is adequate, and your end organs are adequately perfused. So there are different potential markers for adequate pump flow, like mixed venous oxygen saturation or central venous oxygen saturation if you don't have PA catheter in place, oxygen extraction ratio, respiratory quotient, or how much CO2 is produced, or different organ perfusions like nodes or renal oxygenation. The delayed markers are like lactates. So the accurate arterial pump flow measurements are the basics for correct on-pump calculation. So where you are calculating the pump flow, that is more important. Basically with ultrasonic sensors you can calculate what is the pump flow, but So theoretically it should be measured as close as to the patient level to get it correct value. Similarly, the venous flow also you can measure, so that will give you the fluid dynamic circulatory status in the extracorporeal circulation. And different safety features of the pump like arterial line filters, bubble detector, venous reservoir alarm, that should be used whenever it is available. So what are the different things you can monitor perfusion? By clinically by the mean arterial pressure or the warm peripheries, urine output and perfusion pressure and index. Different lab values like the blood gases in ABG, you can see the lactates, hematocrit, bicarbonates, mixed venous oxygen saturation, urea creatinine, and different enzymes like hepatic enzymes, cardiac enzymes, though they will be later, but they will also give a value that there was some ischemia. And early markers of acute kidney injury can guide us. In the monitors, we can have pulse oximeter, NODS, transcranial Doppler, and depth of anesthesia monitors like BIS and entropy. And for the kidney, we have renal artery Doppler, renal perfusion, and TE. For the brain, we have regional nodes to monitor the regional oxygen saturation. Basically, disposable sensors are used to monitor in the anterocerebral artery and middle cerebral artery. So, when you suspect that there are very high chances of injury of brain, like when you are planning for going on deep hypothermic circulatory arrest or aortic arch surgeries and different complex cases, you can put NODS. Actually, basically ASA recommends for all cases in cardiac surgery to put NODS. So when you have NODS with the baseline value of less than 50% or during the intra period, if the value is the decrease in the value of more than 15%, there you have to be alert. Then you have to follow the guideline. First you check for the head position, assess that the head is not over rotated to one side and correct it. Then next thing, you have to optimize the oxygen delivery either by increasing the FiO2, optimize the HB, optimize the cardiac output. If not, then there is either more oxygen consumption. So optimize sedation, optimize the analgesia, that means depth you have to monitor. Then consider avoid hypothermia and treat other causes. In one of our cases, generally we do many of the cases with cervical debranching. In those cases, generally put NODS, and whenever we clamp one side, we see that there is not fall in the NODS value by more than 20%. Because many patients will not have adequate circle of Willis, complete circle of Willis. So in these cases, if you clamp one side of the carotid, then there might be decrease in the NODS regional oxygen saturation value, and in those cases you have to maintain the perfusion pressure above whatever you are maintaining. Suppose you are maintaining around 90 or 100, you have to bring it above 100 or 120 slowly. Then again the regional oxygen saturation will increase. Then you can slowly proceed for the case. If there is no increase in the regional oxygen saturation, generally you defer the cases, and after optimization and checking for the circle of Willis, we take for those cases actually. Next, transcranial Doppler. Here you can see for the cerebral blood flow, but this can even identify the intraoperative embolic load. But the disadvantage is that it needs a proper acoustic window to identify, and it needs a technical expertise. That's why it is not very much popular in the cardiac surgery. Next, different depth of anesthesia monitors like EEG and processed EEG like BIS or entropy. So it can prevent the intra-pulmonary. Normally we maintain between 40 to 60 for all the cases. It is very common with TIVA when compared to volatile anesthetic agents, as in many of the cardiac surgeries we only continue with the intravenous anesthetic rather than volatile anesthetic, because it's easier to maintain unless you have a inbuilt vaporizer in the pump, and it can be used as a part of multimodal neuromonitoring. Then information on the cerebral perfusion. Suppose you have planned for a DHCA, so the adequacy of DHCA and whether you have there is a cortical burst suppression, you can know through the BIS values or entropy values. If they are showing 0, that means your brain it has cortical suppressions are good, and when seizures, ischemia, other things also can be known. Then the different strategies which can reduce the CNS injury. So you can reduce the embolic load, gaseous, atheromatous plaque or air by doing the epiaortic scan and identifying which are the places where there is atheromatous plaques are there. I'll avoid those places for cannulation or cross clamp. Then prevent hypotension, and anti-inflammatory drugs can be given, and avoid hypothermia, cerebral hypothermia while coming up. The most commonly, if the case is getting late, then perfusionist might do rewarming in a very hurry, then there will be cerebral hypothermia. You have to take care of all those things. And during DHCA, you have to give the cerebroprotective agents to decrease, bring to the level of cortical suppression. And cerebral edema, to prevent cerebral edema, mannitol. And if there is cannula malposition, you have to take care of all those things. Then other things, the next organ to be affected most with CPB is the kidney. So there are also checklist what are the things you can do to decrease the CPB associated kidney injury. First thing is hypotension. Hypotension is very dangerous for kidney. So it has to be prevented at all level, like pre, intra and post-operative level. If you have a angio in within 24 hour or 48 hour, better try to hydrate the patient, give N-acetylcysteine. If it's an emergency, then only talk, because it will be a second hit, contrast-induced nephropathy followed by again pump. It might add on to your injury. Then different embolus, IABP. If you are placing an IABP, it should be in the proper place. So you check the IABP position, catheter tip with X-ray immediately after placing, whether it has occluded the renals or not. Then IV amino acid infusion, any drop in hemoglobin as well as overtransfusion, both are dangerous for the kidney. Avoid all the nephrotoxic drugs, especially for the antibiotics. Many of the antibiotics, if you are starting, then if your creatinine is increasing, please reduce the dose and adjust according to the dose. And dopamine, the role of dopamine is controversial, that needs to be taken care. Then ventilation. As in the pump, it is a non-ventilated, the pump will be doing the job of the lungs, but it will not be ventilated. So it's a non-ventilated respiration. The oxygenation here will depend upon the FiO2, whereas the carbon dioxide depends upon the sweep gas flow. So monitoring because there is no pulmonary flow, the EtCO2 and end-tidal anesthetic concentration, those will not be possible to measure. So because of the non-ventilated lung, there are high chances of lung injury in the post-CPB period. So in the pump, hypoxia is dangerous, everybody knows. Even hyperoxia in the pump also will be dangerous, because it will cause the reactive oxygen species, and all the injuries because of that will be multifolded. What are the different strategies to reduce the CPB associated lung injury? You can do to decrease the fluid overload. You can do a MOF or cough along with MOF, so that the fluid overload at the end of the surgery or end of the CPB will be less. And you can use different biocompatible coated circuits which will have less inflammation. You can selectively perfuse the pulmonary artery. Then continuous CPAP or vital capacity maneuvers before coming off those, and you can have low ventilation during the CPB, and different pharmacological interventions like steroids. And while using the blood and blood products, you have to be judicious to prevent TRALI, that is transfusion associated lung injury. Then with the coagulation monitoring is also very, very essential, because the bleeding and coagulation, both are it has to be weighed, because bleeding will lose a patient if the patient will bleed later, and if it's a clot in the pump, it is a disastrous. So most commonly the ACT we measure, but it can have an erratic response, so you have to you have to take care of that one. And heparin is very known to have that resistance, and heparin so you have to be very, very careful while dosing the heparin, because heparin can have resistance as well as heparin can have rebound. So there are many point of care systems which will monitor the hepatic dose response curve for that patient. At that point, that will depend upon the weight of the patient, height of the patient, gender, and how much priming volume have added to the pump, and how much unfractionated heparin the perfusionist has added to the pump. So all those it will take, and at 3-4 points they will calculate, and they will put a curve. From that we can calculate that patient's response to the heparin. So that is known as heparin dose response curve. Similarly, while coming up, protamine, it will reverse the effect of heparin. again heparin, protamine at higher doses more than 8 mg, it can have bleeding tendencies. So same thing is applicable for protamine. So protamine titration assay has to be used. And nowadays with the point of care coagulation testings, TEG and ROTENGs are very useful, provided you have come off and you have reversed the effect of heparin. TEG and ROTENGs can be used efficiently. If you are using ROTEM, heptem is a must to neutralize the effect of heparin, then only we can come to the result that whether I will use cryo, I will use FFP, or I will use platelet. So you have to be using judiciously what the products also. So with this these are the different checklist. So starting from the anesthesia machine, then the perfusionist, what are the things they will check, and pre-bypass checklist, post-bypass checklist.